In this episode of our podcast, hosted by myself, Anna Christofides, the owner of Impact Medicom, we discuss the use of Zanubrutinib for the treatment of Waldenstrom's macroglobulinemia. Our episode starts with a discussion of data from the Phase 3 ASPEN trial comparing the efficacy and safety of Zanubrutinib with ibrutinib in these patients. Our first guest, Dr. Constantine Tam, is a Professor of Hematology at the University of Melbourne and Consultant Hematologist at the Peter MacCallum Cancer Centre in Melbourne, Australia. He is also the lead author on the ASPEN trial and provides a detailed look at the key data from this study. We are then joined by Dr. Carolyn Owen, an Associate Professor in the Division of Hematology and Hematological Malignancies at the University of Calgary. Dr. Owen discusses the potential impact of the data from the ASPEN trial on Canadian clinical practice and how Zanubrutinib may fit into the Canadian treatment algorithm for Waldenstrom's macroglobulinemia. Hope you enjoy it. So welcome, Dr. Tam, and thanks so much for joining us virtually from Melbourne, Australia. So first of all, I wanted to congratulate you on your numerous publications, and I'm excited to hear about all of your extensive experience with Zanubrutinib for the treatment of Waldenstrom's macroglobulinemia. So to start, what do you see as really the key unmet needs for these patients?
Key unmet need for Waldenstrom's macroglobulinemia prior to the BTK class of drugs is clearly the fact that the chemotherapy options are limited and patients do become resistant to chemotherapy over time. And they also suffer from the long-term side effects of recurrent courses of chemotherapy. So when the first BTK inhibitor came around, ibrutinib, it was really quite a breakthrough in that this is an oral tablet that had really very manageable side effects and was able to very reliably control the disease in the vast majority of patients. And most patients on ibrutinib felt great. Their hemoglobin got better, the IgM came down, and they had a pretty good quality of life. However, when working with ibrutinib, we noticed that although the side effects are described as being minor in the short term, in the long term, they are cumulative and they can be difficult to manage in the long term. Probably there are two classes of side effects that are most troublesome for ibrutinib. So the first one would be bleeding. So all the BTK inhibitors are very potent antiplatelet agents, and ibrutinib being more so than others. And then the other one would be the atrial fibrillation, which is we thought initially complicated around 5 to 10% of patients for ibrutinib, but we now realize with long-term follow-up that it probably could be as high as 20%. And because ibrutinib causes bleeding, when these patients with atrial fibrillation require anticoagulants to prevent strokes, and you have to start anticoagulant on the background of someone who's taking an antiplatelet drug, this can be very hard to manage. Probably the last one where ibrutinib can be improved upon is hypertension, which is a long-standing issue. So the longer patients on ibrutinib, the higher the chance of getting hypertension, which of course compounds the cardiovascular risk of the drug. So I would say that now that we've got BTK inhibitors, the main gap in treatment is finding a therapy that has less side effects.
So I understand that now that there are the second generation BTK inhibitors that have been developed. So I'm wondering if you can talk a little bit about those, why they were developed, and what the hope is in improvement.
So ibrutinib has probably two major drawbacks. Firstly, it doesn't get absorbed all that well, so that the drug doses are not that high. And secondly, ibrutinib is somewhat dirty. So in addition to inhibiting BTK, it inhibits a number of related enzymes such as ITK, TAC, JAK3, and so forth. In general, it's felt that probably some of the side effects from ibrutinib may be due to off-target kinase inhibition. I mean, some are probably on target, but many are probably off target. Probably the best illustration of this are patients with genetic deficiency of BTK. So, there is a disease where boys are born without BTK, and these are genetically deficient people. And they don't really get bleeding, atrial fibrillation, or hypertension, which is what we see with ibrutinib. So that suggests to us that, you can knock out BTK cleanly and still have very few side effects. The second generation drugs in general have got better pharmacokinetics than ibrutinib. It's absorbed better with better plasma levels. And also they are more specific. So they are more the target BTK with equal efficiency, but reduced off-target targeting. So they're cleaner in general. Different from the situation in CML, for example, where nilotinib or dasatinib actually inhibit the protein in a different place from the first generation drug, imatinib. All of the current BTK inhibitors actually inhibit BTK at the same place, at the cysteine 481 residual. So if you're resistant to a first generation drug, you will be resistant to a second generation drug as well.
So I understand that the key second generation BTK inhibitors being acalabrutinib and zanubrutinib, and that your trial, the ASPEN trial, really focused on zanubrutinib. So I'm just wondering if you can describe the design of the trial and what questions you hope to answer.
So the ASPEN trial is a head-to-head study of zanubrutinib, the second generation drug, against ibrutinib in Waldenstrom's macroglobulinemia. The reason for setting up this trial was that we noted in the phase 1 study of zanubrutinib that it was very active in patients with Waldenstrom's. In fact, these patients got the response very early, and there seems to be a much higher proportion of patients who got into a very good partial remission of VGPR, which represents a 90% fall in IgM for patients with Waldenstrom's compared to those with ibrutinib. So the ASPEN was really set up as a head-to-head study to compare the results of zanubrutinib versus ibrutinib. And the primary endpoint that was chosen was VGPR plus CR because we wanted an early look to see if zanubrutinib is indeed more effective in Waldenstrom's compared to ibrutinib in causing a response in the IgM. Of course, another important question there was that was there a difference in toxicity profile? Because once again, from the phase 1 study of zanubrutinib, we noted that it seems that the toxicity profile of zanubrutinib seems to be very benign compared to ibrutinib. When we set up the ASPEN study, we also had the problem in deciding what to do with patients who entered the study but who tested negative for the MRD88 mutation. So to put this in context, 90% of patients with Waldenstrom's would carry the MRD88 mutation and would be what I would consider typical Waldenstrom's. So these people respond to BTK inhibitor. Around 10% of patients would be MRD88 negative. And these patients are known to not respond well to ibrutinib. So in order to provide some treatment for these patients, there was a non-randomized arm set up, the so-called cohort 2, for patients who have MRD88 wild-type Waldenstrom's, and these patients receive zanubrutinib without randomization. So to reiterate, patients who have got the typical MRD88 mutated Waldenstrom's, which is about 90% of the population, goes into a study of head-to-head zanubrutinib versus ibrutinib, and those who test negative for the mutation, which is around 10%, go into a non-randomized arm receiving zanubrutinib.
So I'm just wondering if you can just focus in on cohort 1 to start and describe the efficacy results from that cohort.
So as I mentioned before, cohort 1 is set up to show that zanubrutinib has a higher VGPR plus PR rate compared to ibrutinib. And this is a read from the IRC, so from an independent response committee. Now, the read occurred with data cutoff on the 31st of August, 2019, which is the agreed time. And on that read, the study was actually negative in terms of improved efficacy for zanubrutinib. As with any typical BTK inhibitor, there were no complete remissions on either arm, but the VGPR rates were 19.2% for ibrutinib versus 28.4% for zanubrutinib. A numerical difference in about 10% of the response rate, but that did not translate into a positive p-value, which is 0.09. So technically a negative primary endpoint. However, there were other indicators that zanubrutinib was more active, and the study was probably underpowered, and that was probably the problem with the study. The reason why we think so is that when we did a more extended follow-up in January, and we did the response by investigator, the difference now is 30.4 versus 18%, which has a p-value of 0.03. In addition, if you actually analyze the total area under the curve for IgM comparing the two drugs, zanubrutinib had a faster and greater reduction compared to ibrutinib with p-value of 0.03. However, when you design a study, you can't ask the question again and again. So we have to go with what was the primary endpoint, which is that it was a negative study for an improved VGPR and CR rate at the time that the IRC had chosen to rate the primary endpoint. That will go down in history as the primary endpoint of the study, that the two drugs were at least equivalent. I think I would like to say that time will tell, because obviously we will get further reads of the endpoint showing the responses do mature with time. So I think time will tell. And also we'll hopefully see a difference in progression-free survival with further follow-up. So the study was powered to read the endpoint very early with a VGPR endpoint, which was negative, but I suspect that with further follow-up, the time would show that there may be differences. Apart from efficacy, there was a very big difference in toxicity rates, which I think are probably some of the more interesting messages to come out from this study.
Great. And before we get to the safety, I just wondered if you could comment on the rapidity of the response.
So the rapidity of the response was very fast. So BTK inhibitors tend to reduce paraprotein very quickly within weeks. So it was very fast for both. But as I mentioned before, if you analyze the IgM curve and you look at the area under the curve and the shape of the curve, it shows that the reduction was faster and greater for zanubrutinib.
So if you could comment on any differences you saw in discontinuation rates and dose reductions.
To start with, I would say that, we had long suspected that zanubrutinib probably was easier to use than ibrutinib. And it's really quite gratifying to see this reflected in the context of a randomized study, so proven beyond doubt that this is the case. So what we saw was that on the zanubrutinib arm, there was a reduced number of adverse events overall. So there were a reduced number of adverse events leading to death, adverse events leading to treatment discontinuation, dose reduction, or dose held. So across all those parameters, zanubrutinib did better compared to ibrutinib. But when you drill down into the actual side effect, once again, we can see that there were some key differences. The first key difference was that there was a very marked difference in the rate of atrial fibrillation. So the actual rate of atrial fibrillation of flutter was actually 15.3% on ibrutinib and 2% for zanubrutinib. So a 7-fold decrease in the rate of atrial fibrillation and flutter in favor of zanubrutinib. In addition, if you think about the other typical BTK inhibitor type toxicities, which include bleeding, so overall hemorrhage rates was lower in the zanubrutinib arm at 48.5% compared to 59.2% for ibrutinib. And hypertension, which, as I mentioned before, is a really major problem for people who take BTK inhibitors long-term, was reduced, with grade 3 hypertension being 5.9% in Zanu and 12.2% in ibrutinib, so halving of the severe hypertension rate. Now, balancing against that was the fact that zanubrutinib had a higher rate of neutropenia. So the severe neutropenia of grade 3 occurred in 19.8% compared to 8.2%. However, this is more of a laboratory reading type problem because the rate of infection was in fact identical between the two arms. But all of the BTK inhibitor side effects that trouble us when we use ibrutinib, such as atrial fibrillation, bleeding, and hypertension, will reduce with zanubrutinib. In addition, there's a group of side effects that are called a nuisance side effect. So these are side effects that often patients complain about are not deal breakers. And this is things like muscle spasms, so peripheral edema, just generalized pain, and just unwellness with ibrutinib. And all of those were lower with zanubrutinib. So it did seem like a cleaner drug. Had reduced cardiovascular toxicity, it had reduced bleeding, it had reduced nuisance side effects, and it had a reduced number of patients who had to either stop, hold, or modify the therapies because of drug side effects.
Wonderful. And just kind of looking at the neutropenia, do you have any concerns about that? Anything that should be looked out for or managed with growth factors or anything like that?
We often do see neutropenia with a lot of our targeted agents. I do a lot of work with venetoclax and ibrutinib, zanubrutinib. So, really this, we often see patients come in, they're perfectly well, the neutrophils are 0.9 or something. And I have to say that, I typically just send them home with GCSF once a week for, 6 to 8 weeks. I get them back and then usually goes away and I stop the GCSF. So yes, it is something that you watch out for, manage. But I find it's very infrequent that I have to stop or reduce a drug because of neutropenia. Adverse events leading to dose reduction occurred in about 25% of patients on ibrutinib and about half the rate for zanubrutinib. So, and I would imagine that probably only very few patients with neutropenia led to a dose reduction. For MYD88 wild-type Waldenstrom, which is only a small number, 10% of Waldenstroms, the previous Dana-Farber phase 2 ibrutinib study suggests that these patients just do not respond. Now, having said that, they only treated very few patients, so it could be just no patient numbers. But the general, sort of message on the street is that these patients don't respond. Now, on the zanubrutinib study, ASPEN, the non-randomized arm, they actually did really well. Total number of 26 patients were treated. And the overall response rate was actually 80%, with a very good partial remission of 23%, which is actually really quite high. So those numbers don't look any different. I have fairly good confidence that this is actually that zanubrutinib is effective in MYD88 wild type of Waldenstroms. I suspect that had they treated more patients with ibrutinib on some of the studies, that we may have seen a response rate that is higher than zero. But as it stands, the only evidence that we have is with zanubrutinib.
So given those results, would you then feel comfortable using zanubrutinib in those patients that are not mutated?
Yeah, absolutely. Absolutely. I mean, for whatever reason, maybe it's just, because we treated more patients, or maybe because the drug works better, or you get higher plasma levels. I mean, one of the things I haven't mentioned to this time date is that on the phase 1 study, when we looked at the drug levels of zanubrutinib versus ibrutinib, remembering I said that ibrutinib doesn't get absorbed all that well, whereas zanu does. The drug exposure to zanubrutinib in terms of plasma drug levels are somewhere between 6 to 10 times higher than ibrutinib. So we're just talking about much more drugs in the system. And it's nice to see that you can get a lot more drug in the system and still get better side effects.
So having all the results of this study and others, overall, where would you choose to use zanubrutinib over ibrutinib in Waldenstrom's?
I don't want to make an efficacy claim because I think ASPEN didn't make that. So I think it's fair to say that zanubrutinib is at least as effective as ibrutinib in Waldenstrom's, but there's no doubt that it's got less side effects. Probably the only drawback of zanubrutinib is that it's given typically twice a day. It can be given once a day, but most studies with zanubrutinib have been twice a day, whereas ibrutinib is a once a day drug. But apart from that drawback, really, there are no disadvantages with zanubrutinib. The side effect profile is better. The efficacy is at least equivalent. The drug can be given whether fasting or non-fasting. It can be given with a proton pump inhibitor. It's got the same list of drug interactions with antifungals and so forth as ibrutinib. But in all of those drug categories, it probably is easier to manage someone on zanubrutinib than ibrutinib. So I don't see any real disadvantages with zanubrutinib for anything except for the twice daily dosing. Most of my patients with Waldenstrom's will still get chemotherapy. And you have to say chemotherapy does a good job for most patients. Bendamustine, rituximab, or dex, rituximab, cyclophosphamide. That's a good job in most patients. They get remission, they will go for a number of years. And I would say that BTK inhibitors for us usually happens when they've failed either the first or the second chemotherapy, when it seems like, or if the response to the first chemotherapy is short. And then once you start a BTK inhibitor for those patients, for my patients already on ibrutinib and have done well for many years, I don't feel the need to switch if they are doing well in the drug and tolerating well. For patients with bad side effects, I think it's a good idea to switch. But for new patients starting a BTK inhibitor, I think I would give very strong consideration to go on zanu rather than ibrutinib, provided that they can be relied to take the twice a day dosing. There might be a smaller group of patients who are not really fit for chemotherapy for whatever reason. Let's say they've got bad comorbid conditions and they're not fit for chemotherapy. And for those patients, both zanubrutinib and ibrutinib do have evidence for frontline therapy where they're shown to be very effective and well tolerated. So there will be another group that will be favoring BTK inhibitors. And once again, if I am to use a BTK upfront, provided the patient can be reliable to take the drug twice a day, I don't see any disadvantage with zanubrutinib. I will probably go with zanu.
Is there anything else you wanted to add, in terms of Anything that surprised you with patients in the study, or that you wanted to kind of add to the discussion?
I think the one thing to watch out for is that there is an emerging signal that CXCR4 mutations, which is in about 1/3 of patients with Waldenstrom's, may be a predictor of shorter responses with all the drugs, including BTK inhibitors of all classes. So there will be a signal to watch out for in the long term to see whether that's true in ASPEN between the two arms. And if that's true, then those might be the patients where, in addition to a BTK, you might wish to have, add in a second drug or, explore some novel treatment strategy because their responses tend to be a bit shorter. Still pretty good in a number of years, but tend to be shorter. But for all other patients, I would say the BTK inhibitors are doing a great job at the moment.
Well, that's very helpful. And I really want to thank you for your time, Dr. Tam. Thanks again for joining us.
Thank you very much. Wishing you the best.
I hope you enjoyed the discussion with Dr. Tam on the ASPEN trial examining the use of Zanubrutinib in patients with Waldenstrom's macroglobulinemia. In the next part of our episode, we discuss with Dr. Owen how these results may impact clinical practice in Canada. Hope you enjoy it. Welcome, Dr. Owen, and thanks so much for joining us virtually from Calgary, Alberta. Dr. Tam has discussed the data from the 2 cohorts of the ASPEN trial, but as a top hemato-oncologist in Canada, we wanted to get your opinion on how these data may influence clinical practice in Waldenstrom's. So welcome. To start, I'm just wondering if you can describe how much experience you've had in using BTK inhibitors to treat Waldenstrom's.
So I think that's a very relevant question because this is such an interesting disease area. And I think the data for BTK inhibitors is so strong and so clear for this disease. That said, Waldenstrom's is a very rare entity. And in Alberta, we still treat with chemoimmunotherapy frontline. And with bendamustine and rituximab, we actually see very, very lengthy remissions for most patients. So I have a few patients with Waldenstrom's on ibrutinib, but the entry of Zanubrutinib has been too recent for me to happen upon patients. I actually have 2 patients I've prescribed it for within the last month for this indication, but neither of whom have started it yet. I have 2 or 3 patients who've been on ibrutinib for quite a long time and are doing very well on it. I actually haven't had a patient yet fail ibrutinib. So within the Waldenstrom's population, all my patients have tolerated ibrutinib extremely well, but there's only a few of them. When I started using ibrutinib with CLL, I also had a similar experience where the early patients, many of them did very well, but in general, there are a number of side effects. The most notable, obviously, being the cardiac toxicities and the bleeding that I have had a problem with.
So in CLL, in your experience in using ibrutinib, what have been the key side effects that you've had to manage?
So I haven't actually had a lot of problems with diarrhea, which is a frequently cited adverse event for this class of drugs. But the things that patients who complain about that seems to cause a lot of problems, the bleeding and bruising is rarely severe, but when it is severe, it's a huge big deal. And obviously then we don't want to use the class of BTK inhibitors after that because severe usually implies the patient's required a transfusion or hospitalization or some sort of procedure because of the bleeding. But the minor bleeding you would think is minor and shouldn't matter, but it actually does. Patients find it very unsightly, all the bruising. And I do find that my second generation experience, which is mostly just acalabrutinib, that the easy bruising manifestations that bother patients seem less. And then arthralgias would be the most common problem that patients really suffer with ibrutinib, and it doesn't happen right away at the beginning. And a lot of people feel really just generally achy and uncomfortable, and that can improve with dose reduction. But it's definitely something that I think no patient experiences without reporting and complaining about because it's quite symptomatic. And then the cardiac, we're most afraid of the severe cardiac toxicities like sudden cardiac death and ventricular dysrhythmias. But obviously, sadly, patients don't come back and talk to you about those. But the atrial fibrillation problem is one where the patient ends up having to see a cardiologist, be on a whole bunch of new cardiac medications. Often they feel just not quite so well generally when they're on all these medications. So for those patients who experience atrial fibrillation, I find it's a very large impact on their quality of life.
And have you noticed any differences with the second generation BTK inhibitors?
In terms of the second generation that I know, it does seem like the number of patients who complain or the extent of the complaints is less. That it does appear, in my personal experience, that acalabrutinib, for example, is better tolerated than ibrutinib. And being the second generation, zanubrutinib also has this narrow kinase focus. I would expect it would be more like acalabrutinib than like ibrutinib, and that's what the data supports.
Great. And when would you use the BTK inhibitors in Waldenstrom's?
So I definitely think that this is an excellent therapy for relapsed disease. Obviously, when we're talking about a compassionate access program where you can just apply for a drug at any time, then maybe your choices would be different. But I'm thinking about our publicly funded healthcare system and the quality of the data and where I would say this is a really necessary improvement on the current care. And Waldenstrom's is a disease where the patients can have good remissions to chemoimmunotherapy. BR, we also give maintenance, not everybody does. Those patients, many of them cannot be requiring a second therapy for 10 years. I'm not motivated to replace that yet, but the BTK inhibitor class is so effective and seemingly well tolerated for the patients that I have that I would want this as the second therapy and not want to defer it to later lines of relapse.
And so for the patients that have the MYD88 wild type mutation, would you treat those differently, and how so?
So we would not. MYD88 testing is not terribly difficult to obtain nowadays because it is just sort of one gene looking for mutation, a specific mutation. But it wasn't a routine commercially available test before recently. And now it appears to me that typically our pathologists will order it when their clinical impression of a bone marrow result or a lymph node result is in keeping with lymphoplasmacytic lymphoma, which is the WHO diagnosis of Waldenstrom's. And so they will often add the MYD88 testing in a sense to confirm their own clinical suspicion. But if they didn't, it wouldn't change our management. We would still approach the patient as having LPL. And I don't think that our funding agencies, because these MYD88 wild type patients are a lesser subset, there's not very many of them. I don't believe that they're going to force us to treat them differently. And I don't know that they should be treated differently.
So would you be less inclined to give those patients a BTK inhibitor second line though, or?
I'm not sure that I would. I mean, obviously the data for BTK inhibitors in marginal zone lymphoma, which is the diagnosis that is sort of most difficult to differentiate from lymphoplasmacytic, the BTK inhibitor responses aren't as good in marginal zone. And so you wouldn't be as likely to see excellent responses, but it's not harmful. And if the therapy isn't successful, I'm not really sure that the MYD88 mutation negative or the wild type population are a well enough described group that I could state with any confidence that choosing something different would be better for them. So as long as the funding allowed it, if they presented like they were a Waldenstrom's patient, I would treat them like other Waldenstrom's patients.
So just thinking now to the data from the ASPEN trial, what are your initial impressions of the design of the study?
I think one thing that the investigators, the sponsors of the ASPEN study need to be commended on is actually attempting a comparative study in this disease. I mean, one of the reasons that there are no phase 3 studies for a lot of diseases is because it's really hard to run those studies when the disease is rare. It takes a lot of effort, multi-center. And so having an actual comparative study is unusual for Waldenstrom's, to say the least. And I think it's really a bold move on the part of the sort of Zanubrutinib team to have prepared, in a sense, to have a head-to-head comparison. And I think that that's the sort of most important, in a sense, theme that I would take from this specific study. In the end, the primary endpoint was a response endpoint and not a progression endpoint. And although that's logical because it's very difficult to watch for response endpoint that takes a lot longer, I'm not sure patients or physicians are as interested in the depth of the response for this disease because patients suffer with anemia or with hypergammaglobulinemia symptoms. And if those get a lot better and they feel well, they don't really care if they're in a partial remission or a very good partial remission or a complete remission. And historically, with chemoimmunotherapy, almost nobody ever achieved a complete remission, but many of them could have remissions that lasted for years and not be aware of their disease. So I think my only kind of criticism is that the secondary endpoint of progression-free survival, which is sort of almost, not discounted in the study, but it's, it was similar between the two arms. I think that's a more important endpoint.
So can you comment on the findings from the efficacy results and what you would take away from those?
So my impression of the results is that zanubrutinib is at least as good as ibrutinib, and it may be better because the response depth was better with zanubrutinib. So they were reporting higher rates of deeper remissions in the zanubrutinib treated patients. The number of patients in the study is not huge. The median progression-free survival at the time the study is published is very similar. So I would definitely not have any confidence in stating that one drug is better than the other. But I certainly would not expect that ibrutinib would be the better drug. So I consider them really equivalent, recognizing that possibly I'm missing acknowledging that zanubrutinib may actually be slightly more effective.
So just going into the safety data, then can you comment on those results and which AEs perhaps stood out to you?
So again, I think that this study was designed to look at both drugs in comparison, which is really good. We know which side effects of the ibrutinib bother us and are most frequent and bothersome for our patients. But I think that there's increasing amounts of data on the second generation BTK inhibitor class in the more common disease, the CLL, which is sort of better quality data than this small comparison, and that has demonstrated that there are less side effects with the second generation drugs. So I look at this study and I don't think that this study itself is the one that pushes me to think with this number of patients in each arm that zanubrutinib is clearly better tolerated. But I think that when you add this data to the Alpine data, I think that it is clear that there are less of the bothersome side effects of atrial fibrillation, diarrhea, arthralgias with zanubrutinib compared to ibrutinib.
The finding of the neutropenia rate differences, can you comment on that and if you feel that's a concern?
So I think it's very interesting because mechanistically, I find it surprising. And again, I haven't used a lot of zanubrutinib, so I'm glad to know that information so that I can be aware to sort of watch for it. The rates of febrile neutropenia are rare. And so as a hematologist, low blood counts is kind of something I see every day. It doesn't cause me great panic. A grade 3 neutropenia would not bother me at all, but a grade 4 neutropenia would lead me to feel that I need to hold the drug. And again, some of these patients are quite symptomatic. And if this happens early on and you're having to hold the drug and then reinitiate it, it could lead to a lot of extra kind of work for the physician and extra anxiety for the patient. So I wouldn't want to discount it as an unimportant side effect. I think it is important because it could end up causing a need for extra education for the patient and need for stopping and restarting the drug.
Would you use growth factor support in any of these cases?
I think that the data for growth factor support is completely lacking in the setting of BTK inhibitors. And we would be doing that just to make ourselves all feel better and have the number not look low, but that would be costing the patient or the healthcare system a lot of money because growth factors are not cheap. That said, growth factors have become a lot cheaper now that many different biosimilars are available. So I think that across the country, it is easier to access growth factors today than it was a few years ago by a lot, given the entry of the biosimilars. But if I was being completely honest on the application form for Alberta Blue Cross, which is our seniors coverage in Alberta for all patients over 65, non-curative intent disease is not eligible for growth factors. So technically, we should not be doing it just to keep the patient on drug and not have to have the hassle of stopping and then restarting.
Technically, then the best thing to do is just to stop and then start again or reduce the dose then, or? Yeah,
that would be the recommendation. And I think that dose reductions are hopefully rarely needed. Oftentimes, at least I've seen rare neutropenia with ibrutinib and acalabrutinib. If you hold the drug and then restart, often they don't have recurrence of severe neutropenia and they don't require a dose reduction because you don't have to reduce the dose for the first event, only for a recurrence of a severe event.
So based on the overall results of this study and then just previous data comparing ibrutinib to second generation BTK inhibitors, would you prefer to use zanubrutinib over ibrutinib in Waldenstrom's patient?
Yes. So, I mentioned that the last two patients that I have wished to treat for relapsed Waldenstrom's, I have used the compassionate program to try to obtain zanubrutinib. As I said, when I look at the data, to my mind, zanubrutinib is at least as good and possibly might be a bit better than ibrutinib. The side effect profile is likely to be a bit better. So it would be my preference for a Waldenstrom's patient today if I had both drugs available.
Yeah, so I really want to thank you, Dr. Owen, for this very informative episode. And thanks so much for spending the time.